Hi, Dr. Aditya here, back with yet another video on Conceptual ObGyn. So in the last video, I've spoken about pet peeves. Pet peeves are basically those things, it's a phrase in English, which states that whenever anyone is doing some task or something that they say and that irks you, that annoys you a lot, and whenever anyone does it or says that, you get very annoyed. Those are called pet peeves, and I myself carry a few pet peeves of a few aspects of obstetrics and gynecology. One of them was the one that we discussed about IHCP, or that is intrahepatic cholestasis of pregnancy, in the last session. Tonight, I'm going to be discussing about yet another point, and that happens to be a point on which I have just taken a marathon lecture a couple of weeks back. That is urinary incontinence. So, of course, I'm not here to summarize urinary incontinence. It's a 2.5 hour session. I would want you all to go and watch it. It is also there on our YouTube channel. It is also there for our exclusive subscribers, and a few excerpts which I've already spoken there, what I'm going to be focusing on over here. So the pet peeve that I carry in this chapter happens to be that a lot of OBGYNs, especially the old timers, believe that this is a branch, urogynecology and management of urinary incontinence happens to be the urologist's domain. Well, I would like to beg to differ here, because it is completely in a gynecologist's domain, and if you're good enough with your concepts and your surgical skills, you can actually manage these patients all on your own. And the first step to managing these patients happens to be able to interpret the tests that we do for these patients, which are called as urodynamic studies. But before I come to those urodynamic studies, which I have actually described with the help of a graph and everything in that session, I would first want to talk a little bit about what is urinary incontinence. And when I talk about urinary incontinence, it becomes pertinent that I talk about urinary continence. So urinary continence, or the ability to store urine and not involuntarily leak it, is maintained by a few factors. Those few factors are specified in the anatomy. The anatomy of your bladder happens to be three layers: serosa, detrusor, and mucosa. Mucosa being the innermost layer. That innermost layer has two things. First is a layer of urothelium or urological epithelium. It's a single squamous epithelium layer that rests on a basement membrane. Below that basement membrane is your lamina propria, which is in direct contact with the detrusor muscle. That lamina propria contains nerve endings. Now, what happens is, whenever there is any damage to your urothelium and the basement membrane also gets damaged alongside it, this lamina propria is going to be freely exposed to all the toxins or microbes in your urine. So when it gets exposed, because of inflammation and because of all those noxious stimulus, these nerve endings get stimulated, and these nerve endings cause contraction in the bladder. These random contractions are what actually make the patient feel like she just wants to go, she wants to rush and urinate, and she feels that far too often. So the frequency of urination also increases. This is exactly what happens in patients with urge incontinence. Urge incontinence is basically when a female has this urges to micturate, and they are because the bladder is involuntarily, without her knowledge, without her need or desire, is contracting. What apart from this? So remember, we have studied in pharmacology that whenever there is a deficiency of any substrate, the receptor is going to get hypersensitive. Or in other words, whenever there is an excess of something that I'm giving, all those receptors are going to get desensitized. So whenever the opposite of it, that whenever there is a lack of something, those receptors are going to get hypersensitive. So whenever you give even a small substrate back to that receptor, it is going to elicit a huge response. This is something that happens in patients who are elderly and who have metabolic syndrome, atherosclerosis, hyperlipidemia, hypertension, diabetes mellitus, everything. But in this, the most important part being atherosclerosis. Just like because of atherosclerosis, they get ischemic heart disease, IHD, or ischemic stroke. Similarly, the detrusor muscle, which is richly vascular and has a rich nerve supply, it gets blocked. The small vessels that supply the nerves and the detrusor muscle in the urinary bladder, of course, it gets blocked because of atherosclerosis, because of the normal aging process. But what this does is, because of this, there is ischemic necrosis, and the supply of acetylcholine, that is your neurotransmitter, gets reduced. So whenever even small amount of acetylcholine reaches there, there is a huge response, and that area contracts, which is why all your patients with urge incontinence mostly happen to be in the age group of 50, 60, 70, wherein this atherosclerosis has caused a lot of damage to your detrusor muscle. This was about urge incontinence. What about stress urinary incontinence? What is stress incontinence? So whenever there is a stressing factor like I'm coughing or I'm sneezing, and that leads to an increase in my abdominal pressure. Of course, whenever I have some abdominal pathology, it pains whenever I cough. So similarly, these activities increase my abdominal pressure. This abdominal pressure gets transmitted to my bladder. On usual occasions, in normal patients, the bladder just lets it go, it does not affect it. But in patients in whom the pelvic floor is weakened, this bladder cannot sustain those contractions and it moves. Not just the bladder, but even the urethra. The mobility of that urethra is going to be increased in patients who have a weak pelvic floor. This leads to involuntary leakage of urine every time that patient is going to have an episode of coughing or sneezing or constipation. This is called as stress urinary incontinence. I have explained it with diagram in the session that I've taken. Go watch it. Now, why should that pelvic floor be weakened? The biggest factor, especially in India, happens to be multiparity and large number of unattended vaginal births, which lead to complete damage or thinning of your pelvic floor. How do I treat it? If I'm going to treat urge incontinence, first of all, I have to diagnose it. And for the diagnosis, urodynamic studies are very important. For stress incontinence, all the books say that you do not need urodynamic studies, but if it happens to be a case of mixed incontinence, when there is urge as well as stress, you will require urodynamic studies. So what are those urodynamic studies? To talk about the basics, I have spoken about them by taking the help of a few graphs, but to talk about them very simply, there are a few tests that we do. There are simple tests, there are complex tests. So in simple test, a female comes to my clinic, there's a special commode that I have made. She sits there with a full bladder and starts micturating. When she micturates, that commode has a rotating system, basically a bowl which is rotating. So she has to urinate inside it and it starts moving. When it starts moving, it measures a few parameters. First of all, it measures what is the total amount of urine that she has voided. Secondly, what is the total time that she took to void that. And third, what was her average flow rate. So basically, you already know that whenever you go and micturate, initially there is a gradual flow, then the flow increases to a maximum velocity and then it again comes out and it ends. So there's a bell-shaped curve that is made by a normal person while micturating. This machine also measures that whether she is having a single curve or she is having multiple bursts of urination because she is voluntarily trying to pass her urine. So it measures your average flow rate and peak flow rate, मतलब maximum कितना था. So these four parameters are measured and this is called as uroflowmetry, which is a simple form of urodynamic study. Once she is done doing that, then I ask her, her bladder is empty, then I ask her to come to me, I do an ultrasound or I put in a catheter, and with that catheter I try to measure what is the amount of urine that is remaining inside, which gives me a post-void residual volume. In a normal person it should be less than 50. In patients who have overfill incontinence, they tend to have volumes more than 150, 200, 250 ml. Once her entire bladder is completely voided, then I start injecting saline inside her bladder using a catheter. When I'm doing this, I start measuring the first instance or when the female is going to have a first episode of leakage of urine. I also measure the pressure that is created by the bladder. Whenever the pressure is created, the bladder is going to give an indication that there's going to be a spike in the graph, and that will tell me that this female is now experiencing urge. So the urge which should come at around 150 200 ml, the women with urge incontinence get that urge at around 50 to 100 ml. So it is going to be happening much earlier in them. This is called as filling cystometry. Lastly, there's a form of complex urodynamic study wherein I measure each and every pressure. Which pressure? First of all, I put in an electrode inside the bladder to measure the bladder pressure. Secondly, I insert another catheter inside the urethra, which measures the urethral pressure. And a third catheter that is going to be inserted inside either the rectum or the uterus, which will measure the abdominal pressure. Then I ask the female to cough. On coughing, the electrode inside the rectum or the uterus is going to show a spike because there is an increase in abdominal pressure. I will then see what is the pressure that is achieved by the bladder and of the urethra as well. Calculating all this is going to give me an idea whether she is having urge incontinence, stress incontinence, or overfill incontinence. All of this has been explained in the video that I've shot. I've used multiple graphs. I would want you to go and see them. And with that, this is Dr. Aditya signing off. Keep watching Conceptual OBG. There's a lot more to come.